So we're going to move on to our next debate with Andre and Hal. And this time we're going to give you an hour, actually, for this one. Hal's going to start.
How wonderful this whole experience has been, and how important he's been to everybody here. The talk that I'm going to give now is the result of 45 years of thinking and work. And and I appreciate very much giving it a little extra time, because this is something that really matters to me. And I hope it matters to you, and I think I have some answers that you'll find if you don't find them interesting, don't tell me, okay? It's the ETB CPC. In 1973, I went to my first meeting of neurosurgery in Los Angeles, and Fred Epstein got up there and said something that absolutely blew me away. And let's see, we'll start off with what I'm supposed to be talking about. And these are the questions that I want to answer in this talk. What is the role played by the ETV? What is the role played by the CPC, the choroid plexus coagulation? Am I a problem for you?
You're not the problem. I am.
What? Oh. I'm so energetic about this particular talk that I can't stand it. So what is the role played by the ETV? What is the role played by the choroid plexus coagulation? What is the role played? The most critical role is the effect of atmospheric pressure on this problem. What is the role of the brain, and what does a shunt do? So these are the questions that if I were given this to a group of residents, I'd send it out to the audience. And I think this is really important. Somebody should answer this. If you have a premature baby who's developing post-hemorrhagic hydrocephalus, and you treat them with an external ventricular drain or whatever that you do, how long will it take for the ventricles to come back to normal? Okay, Andre has given us the answer. Yeah, residents. Yeah, whatever. You can't get them to ultrasound fast enough to see a change in the ventricular side. They're absolutely immediately, it's gone down. And in full-term babies, say a 6-month-old who's developing hydrocephalus, and let's see if the trainees can give us the answer. How long does it take after you put a shunt in for the ventricles to become normal? Anybody? It takes 4 to 12 months, and so it's not a quick thing at all. So now now the patient is now 12, and he's had a shunt in since he was 6 months old, and he now blows up his ventricles, and he's really sick. How long does it take after you revise the shunt for the ventricles to come down? Yeah, you can't get him to the scanner time enough to see the difference. So what's happening here is that this is a distortion of the brain, and what you do with a shunt is you suck it down, which isn't done by a third ventriculostomy. So these are two critical papers in my thought process. I've always, as I said in the previous talk, I've always been so offended by the concept that for every diagnosis there is a treatment, and that's the only way that people who plan economics can deal with the issues. But it means we're not identifying how this thing is happening to this patient. And I think that's the critical thing, and maybe it's a good thing that I'm at the end of my career, because I can't adapt. So this paper was the paper that was actually presented at that Congress meeting, where Fred Epstein and the group there's some previous work with cats that led to this, but he treated patients who were premature. And I understand from my friends that this was done by Dandy as well with other forms of RAPS, and I didn't know that until this morning. But
Back to Severing House, 18th century. So beautiful picture of an
Well, how come it took me so long to find it? That's I mean, and he wrapped the heads of these premature babies and to prevent them from needing a shunt, and it worked. It had some complications with it, some sloughing of the skin and some things like that. So it was abandoned, and probably because he was so controversial at the time, that was probably another reason why it was abandoned, but it was abandoned. So now we have this article. That's 45 years later, and I think this is equally important and really critical. This article by Kulkarni, Worf, and Schiff. And there are three different groups that are here. Ab Kulkarni is a Toronto Sick Children's, and he's the world's expert on statistics. and the statistical analysis of this is quite controversial. But Steve Schiff is a MD, PhD, was a pediatric neurosurgeon, and is now really an engineer and brilliant person at Penn State, who has developed techniques where he can actually measure the volume of the brain. And that's been a real problem. We can always measure ventricles, so we always talk about ventricle size. We don't talk about brain size. And I think that explains why it's okay to have big ventricles after a third ventriculostomy. And in this particular paper, in the Ugandan children, all of them showed that as long as the brain volume was okay, it essentially didn't matter how big the ventricles are. So it's the volume of the brain that matters, and not so much the volume of the. And so that depends on the size of the skull, doesn't it? The reason that it takes 4 to 12 months for the ventricles to come down in a patient who's a full term is that the skull's too big. Nature abhors a vacuum. And so if you suck it down, it can do one of two things. The brain can collapse, which is why it took so long to have an adequate treatment of hydrocephalus, or the brain can regrow. And thank goodness in a 3-month-old or a 4-month-old or a 5-month-old, there is a growth pattern, but it takes a long time for the brain to regrow and fill in that space. And so Ben Worf, one of the most remarkable people I know, he was for a very short period of time a resident with me. He had a practice. He was a missionary, a medical missionary in Uganda, and treated children at the Cure Hospital. And he has been a driving force in this process where many people from the first world are now spending months or years in places in the southern, below the Sahara Desert. So it's a critical group. Each one of those three groups presented this, 2 of them at the ISPN meeting in Denver, and one at the pediatric section meeting in Houston. Where was that? Anyway, I divulged. But anyway, this is the end of the stream of the first paper, right? So that the problem now is we do a third ventriculostomy, but it doesn't really work because the ventricles don't come down, and that's the reason it doesn't work, because the skull is so distensible. The fontanelles are open, they're bulging. The head grows at 2 centimeters a week. So it's just wildly growing. And it's not surprising that the ventricles won't come down very quickly after that, because there's still some pressure in there. So the critical points made by this paper, which I was so excited to see this paper. And it was in the New England Journal. Whoever's talked about the New England Journal being the important place this was in the New England Journal. And it was allowed us to have accurate volumetric measurements of the brain, which was on CT scans done in Uganda. I think that is a remarkable thing. And Steve, I've been talking to him online. He's trying very hard to get the software so that it's generally available to all of us on our scanners, because I think we should start looking and do our calculations not at brain volume or thickness of the brain, but on the volume. And it's really amazing because you know, the stacking dolls, the Russian stacking dolls. The volume of a sphere is the cube factor, and so a little bit of increase in size on the outside is overwhelmingly more important than a lot of increase in the ventricle size. So we really need to, if we're going to really look at this and understand what's happening, we have to know what the volume of the brain is. So this is the definition that I don't take it, it was my paper, but it took 22 of us got in a room 3 times and decided to find a definition and a classification of hydrocephalus, and this is the definition that we decided upon. It's an active dissension of the ventricular system of the brain related to inadequate passage of CSF from its point of production within the ventricular system to the point of absorption in the systemic circulation. And this led to this classification, so that all hydrocephalus in one way or another, except for choroid plexus papilloma maybe, is an obstruction. Now, in children, in babies, if you tie off the jugular veins of infants, they'll develop hydrocephalus, right? Because the head will continue to get bigger because it can't absorb spinal fluid. So it'll be an expansion both the cortical subarachnoid space and the ventricles. And so then when you shunt them, what happens is the skull stops growing, and there's no, and with the, anyway, this is what we just said, right? That if you have a normal preemie versus a patient with posterior hemorrhagic hydrocephalus, the head volume gets very, very big very quickly, but the brain volume stays about the same and returns to normal immediately after the shunt is put in or whatever is done to him. Let's see if I can do this again. And this is what's, I just wanted to show this is what's happening. So this is in a premature baby. The baby starts out normal, and then they develop. And we know that for most of them, the point of obstruction is between the spinal and the cortical subarachnoid space. We know that because they were effectively treated with intermittent lumbar punctures in infancy. That was a protocol that in the 70s and 80s we were using all the time. Now we use tapping reservoirs or something else. But the head grows so rapidly, and the ventricles develop very quickly. So after the shunt creates a negative pressure and pulls the spinal fluid out. Whereas the third ventriculostomy gets rid of a point of obstruction where there probably isn't any between the ventricle and the choroid and the cortical subarachnoid space. Or at least we know it can get into the lumbar theca. So what the problem is that we're seeing atmospheric pressure. The brain is seeing atmospheric pressure and not being constrained by the skull. All right? So what happens if you if the head gets bigger and bigger and you put a shunt in is they end up growing their bone, so that if a patient is treated in infancy for severe hydrocephalus and you see them at 13, they're going to have a skull that's 2 centimeters thick. So this is what happens when you have a full-term baby or a toddler. The skull gets bigger and bigger and bigger, and then the brain has to grow once you put the shunt in. It stabilizes. It doesn't get, and that's not what has been said to be it's not a real craniosynostosis because the skull can still grow. It's been shown clearly that the brain it doesn't stop the growth of the skull, but the brain has to catch up to get there. So what does choroid plexus coagulation does? Well, we know that in people who've had choroid plexectomies, that 6 months later, the rate of CSF production is the same as normal. But probably 40 to 60% of CSF in patients who have choroid plexus is created by that. So what you've done is you've slowed the process. By doing a third ventriculostomy and a choroid plexus coagulation, you're slowing the amount of CSF that's being made in these premature babies, so you're giving it a little more time. And that what's happening in that little more time is the skull's thickening and the fontanelles are not as distensible. So it does add a little bit, but it isn't the answer. So we know that the very young child is the least likely to respond to ETV, although there is some improvement in the outcome. And as I said before, it's not a shunt, it's a sentence. And it's a lifelong sentence to these people. If you can do anything to prevent them from having to have their first shunt, you've done amazing things for the quality of their life going forward for the next 70 years. Choroid plexus coagulation does not deal with the point of obstruction, but it does slow the process. And we'll soon have the ability to accurately measure the volume of the brain, which allows us to test these hypotheses. I think they have to be seen as what I'm talking about now has to be seen as a hypothesis, but it's a completely testable hypothesis, and I'm too old now for me to participate in that. So I've got to find some new young people to take this mantle and try to help do something which I think can be a very valuable people to these premature babies. This is the answer. All right, now we have these molded helmets that we use for children with craniofacial disorders or for plagiocephaly. And you can make them so that they have a screw thing that you can open up at time and watch the brain volume grow. You can over time, you can put just a little bit of pressure on it so that it allows an outside pressure, so it prevents the brain from the ventricles from growing too big. And you can measure it, and then you can get bigger and bigger and bigger until it gets to a normal size. Then by that time you can take it off. Now, I'm not saying every child is going to do this, but I bet you a very, very high percentage of premature babies will be able to be done like this and not need responding to, for the rest of their lives, having these shunts that are always worrisome. And I appreciate, again, everybody listening to me. This has been a 45-year thing to get to this point. So I hope I could do it in 20, 25 minutes. Thanks.
Yeah, and show, yeah. Next. Well, thank you, Hal. That's, I think that most of the things, it is actually the second one, the debate, yeah. Most of what we know about hydrocephalus, we know from you. And that's, I really applaud you for that. It was your lifetime career. And to be honest, he had a nickname. It was Hal the Plumber Rekate. The plumber means that's the drainage system I have to defend now. Let's see if I have, yeah. So it is odd because I, when I first did my first ETV in 1989, I had to fight quite a bit. People were thinking that it was absolutely outrageous and crazy to put a metal scope into the head of a baby to do something, choroid plexus coagulation or an ETV. But, well, Naren said, well, he can also defend shunt, and he will do so. Because it is, if we look to that, and in my career, I have worked a lot with shunts. If you look nowadays, I mean, all of you have done shunts. I'm absolutely sure. Everyone have been involved. You all know them. Probably you also hate them because revisions are not done on Friday morning at 11 o'clock, but usually Tuesday night. And then it is the resident that can replace that ventricular catheter. So at one point, if you have done enough of them, you don't like them that much anymore as resident, because then it is typically a resident type of, of procedure. But worldwide, I mean, of all the types of hydrocephalus we are discussing, the shunts are still around. 25 years ago, we were discussing about future of neurosurgery. We were thinking, well, robotic will be there, so we will work much more with robots. We will certainly have no shunts anymore. We will not use any kind of tree-fine. Come on, who will use a kind of real drill to open the skull? That could all be changing. Well, now we are 25 years ahead. So, and we are not using robots, we are still having shunts, and we are still using drills to open the skull. So that was about future prospects. And shunts are still around. The good thing is about shunts, we have a lot of experience with it, and we have to remind ourselves that it was because of the shunts that hydrocephalus became a treatable condition. Before that, it was a fatal condition. So really it changed, and nobody of you, and not even Hal, have seen that period that these kids would die from that. And you know that Holter had an own, Casey Holter, his son was born with myelomeningocele and developed hydrocephalus, and that was the reason he developed the shunt at his kitchen table himself, and went with this structure that he made to Spitz and Nilsson, and they implanted that, they sterilized that, implanted that, and well, he died of the complications afterwards at the age of 5, but it became a treatable disease because of that. It's simple, and I think maybe that is the advantage of the shunt system. It is a simple idea. You have a catheter, you have a catheter inside the ventricular system, so you can divert the CSF into another part of the body. And that could be the heart, could be the abdomen, could be even any kind of organ. And I can tell you, yes, it has been placed in more or less any other organ that we have in our human body. So the components are easy. You have this ventricular catheter, then you have a kind of valve system that controls how much is going out, and then the distal catheter bringing it somewhere else. That's the attractive part of a shunt. I don't have to show you this, but maybe I have to show you this, that people often say, listen, worldwide we have the availability of 250 different valves. And the conclusion is, well, that means there is not a real good valve, because if there was really a good one, we were all would using that one. Well, it's maybe not true. Looking to the street, we have 16,000 different types of cars, and if there would be really one good car, we would all driving in it. Maybe it is the Tesla, I don't know. Self-driving car, we don't have to drive it anymore. But until now, no, we have the choice. Also in cars. And that's also about with different conditions, you have different possibilities. I still doubt that we need as much as is written here, but that is also typical. Everyone wants to contribute to that. We had the first generation, the very simple one, the ball and cone, and then the distal slit, proximal slit, and then start with pudens, the first reacting with a membrane inside. Still know that, the pudens valve, I think is very common, membrane type, but it belongs to the first generation. Then somewhat more fancy became. We wanted to have it adjustable. The anti-siphon, because that was already known in the 70s that we saw this over drainage. And I was mentioning that in 1984 I had my first patent on an percutaneously adjustable hydrocephalus valve, but nobody was interested in that anyway. But we have seen some developments, and we have now the gravitational shunt by Mietke. So we have some possibilities that comes more close to the physiology of our different positions, because we are not only bedridden, fortunately. We walk around, we bend over, we do a lot of things, and also kids and adults with hydrocephalus will do the same. And it was very difficult to adapt to the normal physiology simply because we didn't understand that normal physiology so well. Problem of a shunt, why didn't we like it? Well, the shunt survival rates were not that great. If you look to that, that over the time, in the days, many of them fail. Yes, and we remember them. We know that more than 20% will at least have one revision. And the unlucky ones, 1 out of 16, will have 3 or more revisions. My personal record is 76 revision in one child. That is not the kind of record you want to have, because still when somebody would call that name, I still start to tremble. I said, oh no, please, oh God, don't let it come. But that also means that 2/3, 65%, will not have ever a revision of the shunt. So more or less is functioning well with the shunt. But I learned also from Hal that it was not because the shunt is so good, actually because nature is so mild that we even can functioning well with such a badly designed thing as a shunt. Nevertheless, they do well, and at least their hydrocephalus is controlled. So this is maybe forgotten because we don't see them back. They don't come on Tuesday night. They don't need a revision. They go well. So shunts are still something that is a possibility to live for a long time with a disease as hydrocephalus. This was also a nice study. Well, I think you all know that the younger the age is that you implant the shunt, the higher the chance that they will need a revision. And that's true. This is actually a clinical thing that we tell parents of a young baby that we shunt in early age, that we tell them a high chance within this first year of life, the baby needs another operation. You have to be aware of that. Same here, this is of the study by Drake and Kessler, that after 4 years, only about 41% of the shunts are still functioning. But just to summarize and to say, well, of course, ETV has changed the whole fate of hydrocephalus and the fate of many patients. And I agree with this new study in New England Journal of Medicine with the plexus coagulation that is now also coming up again. We will see how this will affect our future treatment. I just summarize, and then we can start a debate, because I hope actually that you will debate with us, not only Hal and me, and getting into a fight, in a fist fight. We already threatened a few times. That's good, but also you, because really, you know about this. You all have done shunts. You probably also have seen an ETV, so you have your thoughts about it, and start also debating with us. In summary, shunts can be used for any type of hydrocephalus. For any. Don't even have to know what type of it is. Shunts can be used at any age. So this is still going on debate. ETV below the age of 2 has a low chance of functioning. Shunts work at any age. And indeed, we will see that there is a frequent need for revision, and yes, there is always some kind of anxiety if they have headache. Oh my God, it will be my shunt again. To revise it is not the most complicated procedure for us, and we can help somebody with an easy procedure to prolong again. So I think many of you, during your career as a neurosurgeon, you will still see shunts being around. Thank you. So let's debate. Any questions on that? George, you moderate.
Looking for some questions.
There was a paper last year, to both of you, Hal, published in Nature Medicine, I think, on
inflammation-induced hypersecretion of CSF in post-hemorrhagic hydrocephalus as a driver for the hydro, as opposed to the other paradigms. How do you think that fits in, Hal? Do you think that, do you believe it? Do you think it's potentially a game changer in terms of therapeutic interventions? They had a drug target as well.
I didn't see that article, but I don't see it as a game changer. Yes, that there are we know that in post-hemorrhagic hydrocephalus that the TGF beta and the patient will be more likely to have a progressive disorder if the inflammatory markers are high, which leads to scarring and leads to all the things. I don't think that's at all. And yes, if they're not a non-toxic, I mean, giving drugs, that kind of drugs to premature babies seems a little, but it's worth it. I do think that the inflammatory markers, whether it makes more CSF or not, I don't know the answer to that. But I do think that inflammation plays a big role in scarring and plays a big role in post-hemorrhagic hydrocephalus. How about you?
I'm not thinking that the hypersecretion, was that where you say that the cause of hydrocephalus is hypersecretion of CSF?
It's very, it was pretty controversial to my understanding of post-hemorrhagic hydrocephalus, but there was I think it was a threefold from memory increase in CSF production in response to this inflammatory change. There was upregulation of genes responsible for CSF production. I mean, it was a Nature Medicine paper.
I wonder how it was measured, this production, because a lot of studies that the elderly studies about production of CSF were not properly done. So many new studies, and I refer to this what had been done in Croatia, is actually showing a much lower secretion than previously thought. So I don't know. I don't know the article, to be honest, but I don't know how they measured it.
Maybe mice have a higher.
Well, the measurement of CSF production is not a trivial thing.
Oh, no,
I mean, to do
not.
ventricular lumbar infusions is the way it's been done in humans. So getting some, as part of a study, getting an idea of how much CSF is made, is formed, is very difficult.
To do.
Now,
Yeah.
I did in the lab, published, I did just an infusion study. I did ventricular infusions in normal animals at high levels and high pressures for long periods of time. And if there was no point of obstruction, there was an 8% increase in ventricular volume. So it alone, extra CSF, and there's probably some evidence that choroid plexus hypertrophy can lead to ventriculomegaly of modest size. But when you put an obstructive thing in it, it went by 40% increase in the ventricular size. So you can get, just from choroid plexus papilloma or just from choroid plexus hypersecretion, you can get larger ventricles. And I wouldn't be surprised if the inflammatory markers, which we know are a marker, that people were advocating getting the inflammatory markers to decide whether to inject the anticoagulants into the ventricle to clear the blood. I don't think that got very far either, but it's interesting.
Pardon my ignorance, but I noticed, Hal, that you had a slide that said the effect of CPC is reversible after 6 months.
It's not, well, the amount of CSF made is the same 6 months later after a choroid plexectomy.
Is that based on animals? Or?
No, it's in humans.
Really?
I think that's Millerot.
And it started already with Dandy. He also showed after fulguration of the plexus that after 6 months the same amount was there. And he said it is from the ependema. So the choroid plexus is not the only site. And that's again human nature. If they need the CSF, they find a way to produce it somewhere else. It is not only by the choroid plexus.
Right, right.
And for a premature baby, they usually make about 70 cc's of CSF a day rather than the 400 cc's that an adult weighs. And so brain volume is identical to the rate of CSF production. So it's a byproduct. A lot of CSF, probably most of it, is a byproduct of brain metabolism rather than the choroid plexus.
Yeah. Yes.
So, Hal, why do you think the North American results of ETV CPC aren't coming anywhere close to the Ugandan experience? Do you think it's just the difference in diagnosis, or?
Well, the Ugandan experience is specifically for post-infectious
Right.
hydrocephalus, and there are criticisms of this paper. They worked on it for 2 years to get it together, and it went through a number of iterations. I don't think the choroid plexus coagulation does much of anything. I think that what it does in this group is that the ventricles still got big. The ventricles really got bigger, but they were
brain increases.
They were huge ventricles
Yes.
in the good results, but they were big ventricles with big brains.
Yeah.
And so I think that they didn't develop bulging fontanelles. All of the statistics that we use about how do you decide whether to take a baby to surgery to do a shunt, a lot of them are shunted because the ventricles have gotten bigger, and that they measure something, and Frank Nelson's my major mentor. He said if the thickness of the brain got to be less than 3 centimeters, then you were malpracticed not to have shunted them. And I think that we have to look at that critically. If you look at the brain volume and it's normal, and the patients are normal and are meeting their developmental milestones, you don't want to walk around looking like a light bulb for a head. But it probably is not to their benefit to have a shunt.
Right. Probably make you less likely to intervene in the neonates who have big ventricles and post-infectious hydrocephalus. You might be less inclined to intervene quickly, right?
Yeah. The most important answer from the mom study is that we've been shunting too many spina bifida patients all along.
Too early. Too early already. Yeah. We were not waiting for.
So Hal, I mean, you're saying ETV CPC is the treatment of choice for hydrocephaly? Is it?
Yeah, because there's no other source of CSF except if you've taken the choroid plexus out, they can't make CSF at all because they don't have a forebrain. And that's from Alabama.
Are you doing the ETV or are you just doing CPC? Because I
For
mean,
that
some of
group?
these hydrocephalic
Only
children.
CPC you can do.
It's all you do is a CPC.
Because you don't find any
Because
floor.
I'm saying you're not seeing the floor.
You
of the
don't
third
see the
on-
floor.
Correct,
Exactly.
so
No,
That's very
it's
difficult.
not.
it's really just the CPC.
It's just a CPC alone.
Yeah.
And that I think Sherry Oakes was at least one of the authors in that article.
Could be.
Do you have explained why if you insert the shunt earlier, he may need or require revision more than if you insert it later, as you mentioned in your study, and the difference are only days? This is first question.
The higher risk of infection. That was the main reason. So if you see shunt revisions, was mainly due to infections, and also mechanical problems. There were apparently more ingrowths into the ventricular catheter.
So what's happening? The organism is a completely different organism at 2 than they were at 3 months. The rate of brain growth has plateaued and is very slow. The brain is growing inward towards the ventricular ventricular volume. They go from always recumbent to all of a sudden they're walking.
Yeah.
And so they have negative intracranial pressure anyway. So the reason is that when you do, first of all, if you do shunts for hydrocephalus after aneurysm surgery, the reason that they don't fail is because they do fail, but they don't care. And that's that.
We don't diagnose those. That's right.
That's the issue. But in children, they're growing, their physiology is changing, they're growing taller, their heads are growing bigger. So what you do for them in infancy will affect the rest of their lives, but what you put in them, their growing will change too. So it's, yes, there's an infectious part of it, but it's mainly the fact that the organism is changing.
So your advice for the timing of shunt insertion, especially with if there's a hydrocephalus with IVH, and do you advise for EVD before that?
Well, what you heard now is it would be ETV and a head wrapping, a helmet, wrapping the head.
Yeah,
would be,
I mean, I could
at
make
least the
that happen.
counter pressure of the skull then.
Yeah.
But I don't know how you can convince your colleagues and the pediatricians at your facility back home, where you come from here, and you would start doing that.
But we have influential people in this room, and
Yeah.
we have new minds who are going to not deny it so quickly. So I think there's hope for the world.
But I
And
remember the first case that I treated a negative pressure hydrocephalus with a neck wrap,
Yeah.
and then subatmospheric EVD. Well, the next hour, the people in the ICU were completely, they were removing that immediately. He said, he's going nuts.
Well,
Because he didn't understand
I presented
the
a
thought
neck
behind
wrap
it.
for a negative fracture
I know that.
hydrocephalus at an ASPN meeting in Puerto Rico, and I told it there was 2 or 3 case reports, and when the lights went on, every hand was up. Every hand was up. They just
What is that? We are strangulating our patients. Yeah, no, but it takes time to understand the difference. The same with the ETV. The first ETVs were simply not accepted because the pediatricians were sending them back after a week and say the ventricles are still big.
yeah.
It doesn't work. I mean, the baby was fine. The fontanelle was soft. Was not vomiting. The baby was growing fine. But the pediatricians did an ultrasound and say, didn't work. And a lot of them went, even if we didn't place the shunt, they were sent somewhere else to do the shunt. It takes time to change the minds of people.
From the point of this, there was a quote, and I can't remember where it came from. That from the first onset of a new idea, it's the minimum of 11 years before
Yep.
it becomes accepted.
There's a typical acceptance curve
Yeah.
for new technology. Yeah.
I've just a question. I've not that long experience like you, Hal, so I have a question to both of you. When I have treated the children with hydrocephaly and so on, with long-standing shunts and so on, I got the impression that those children or young adults who had a shunt that worked well, properly, over years and years, may lose their ability to reabsorb their CSF. So this is not a training effect, but the contrary to a training effect. So if in such cases where you have a low opening pressure of the shunt, you have a well-functioning shunt over years and years and years and years, and this shunt breaks, so it stops its function within minutes or something like that, then these are the patients that are most danger to get a high pressure into the head. So my impression was, and this is my question, if you have the same impression, the same experience, that the ability to physiologically reabsorb your CSF is lost when you bear a shunt that makes more than is necessary.
Well, yeah, I think especially in those who had really, really small ventricles. So in these young adults that were shunted very early on and had these hardly visible ventricular system, so constant sucking out of the CSF, no normal availability of CSF, they had a more or less stiff brain. That's right. But still, some of them, they, when there was a shunt dysfunction, all of a sudden they could be managed with an ETV, but they take much longer, not only physiologically, and sometimes the brain really can adapt, but it can not a few days, weeks of that. And if after that, it is also psychologically very difficult for them, after all of their conscious life being aware of the fact that they needed a shunt to survive, not having it again, every single moment of headache, they were presenting at the emergency department. That sometimes takes very long to convince them that it is not a pressure problem anymore. And thanks God, and you don't have it, but some of these we have given telemetric ICP measurements. So we implanted the telemetric sensor, and then we could show them that it was not a pressure problem. That was really a big advantage. And you don't have them, but that really helped. Yep.
So get your pens and papers out. This is the answer. All right. So I've been blessed and damned by being a destination person for shunts from all over, and people came to me with 75 shunt revisions already. They'd had 700 CT scans. They were in the emergency room. So the first thing I did was I put an ICP monitor in the first and classified slit ventricle syndrome into a variety of different things. And finally, it got to the point that you had to do something different. So in those patients, I programmed them to get the shunt out. And there were several different things. You take the shunt out, put an external ventricular drain in, and then blow the ventricles up. So about 50% of them, or 70% of them, their ventricles grew just like everybody else's. And I did a third ventriculostomy, and 80% of those patients left without a shunt. 80%. They could absorb their own spinal fluid, but they had an obstructive component. Then there were a number who I took the ADV out and put the ventricular catheter in and turned off the shunt, and nothing happened. Their ventricles got a little bit bigger, but not much. They were totally asymptomatic, and the pressures were never on. Then there was the evil ones. And that's their fault. The evil ones are patients whose individual problem relates to venous hypertension. And so if you tie off the jugular veins of babies, they'll develop hydrocephalus. And you shunt them, what happens is their ventricles collapse quickly. The cortical subarachnoid space distends because there's a distal CSF absorptive problem into the venous system. It pushes the brains inward. You take the shunt out and put an external ventricular drain in, and the pressures, I measured a pressure
over 50.
Over almost to perfusion pressure levels, and they can't grow their ventricles because of it's not because the brain has changed, it's because the cortical subarachnoid space is distended. So they need, and David Frim and I, both on the same night, just after 9/11, the December meeting in New York, and we all treated them with lumboperitoneal shunts because it imbalances the CSF between the ventricles and the cortical subarachnoid space. And unless you access the cortical subarachnoid space, you'll never get them better. So I really strongly recommend that people embrace this. That means that well over half of the patients who have chronic headaches and are in the emergency room all the time can be shunt-free, even though they've had their shunts for decades.
What we did in those few cases was a microsurgical ventriculostomy, going through a suborbital approach, opening all the basal cisterns, and then through the lamina terminalis did a ventriculostomy. So a microsurgical one. Mm. And if that didn't work, then a lumbar peritoneal shunt.
Okay.
Yeah. That was published actually by Dr. Van Lindert, who was also here.
I'll look for it.
Yeah.
What percentage of your microsurgical third ventriculostomy really succeed? Were you able to get success in a few cases?
I have not the exact figure. I was just saying, yesterday Dr. Van Lindert was here talking about it. He published that on these microsurgery. There are only a few cases. And I mean, these are they were always the difficult cases. I mean, it was more or less, we don't know how to solve the problem case. And but I think he had certainly half of them were indeed long-term successful.
Yeah, thank you for the talks. So on a daily practice basis, on a hydrocephalus force, the hemorrhagic hydrocephalus, we should try, or maybe we should try to perform a ETB before putting a shunt. or do you usually perform any predictable score to know your selection of the patients before putting the shunt? And if you finally have to put a shunt, do you consider always to put an anti-siphoning or anti-gravitational device or something like that?
So before you answer that, that was my question. Just a question for the trainees. Full-term baby born with aqueductal stenosis. Question is, how would you treat? Who would do an ETV? Just raise your hands up so we have them. All right. Who would shunt that baby? And who would do something else? Hal, that's you.
Well, if they're full term, then I don't think that their skull is that distensible. I wouldn't just wrap them at the moment. But you have to understand also that a very high percentage of people with diagnosis, they should call it triventricular hydrocephalus rather than aqueductal stenosis. And the reason being is that a lot of people who've been called aqueductal stenosis, the hydrocephalus causes the aqueductal closure rather than the other way around. And after the shunt, or after do the third ventricle, I published a series of adults with aqueductal stenosis forever and ever, who after they had their third ventriculostomy, the fourth ventricle, the aqueduct was completely open. So the only real aqueductal stenosis is the genetic one, but for most of them, it's a secondary to something else. So I'm getting off the track.
But based on the International Infant Hydrocephalus study, in that age group, a shunt would be preferable. But what we do now is that if there would be a shunt dysfunction after the age of 2, we do an ETV.
Well, it's interesting that there was primarily in Europe, but also Jonathan Roth and Shlomi did it too, of ETV in babies, the effectiveness of it, and post-hemorrhagic and post-infectious hydrocephalus, with really fairly exciting positive results. And I quote that all the time because I always like to find people that support what I want to do.
So, if you are going to put a shunt, will you use with anti-gravitatory or with anti-siphon devices?
Well, there are anti-siphon devices and there are anti-siphon devices, and they all work. They all in an older child or an adult, they all are as close to interchangeable as you can imagine. But in babies who can't get the pressures up and who don't have they're not up most of the time. If it's a flow resistance, I would be hesitant to do it. Yeah. If it's a gravity thing, I wouldn't have much. I don't think it would have any effect, because until they start walking, I don't think it does anything. So I mean, you guys from the Europe know more about those than I do.
Yeah, we use them all the time. The gravitational shunts, yes.
Yes. Same question, same answer. We would definitely use a gravitational valve also in the newborn, because we just try to prevent to change the valve, which would be nearly inevitable if you put in only a differential pressure valve. Yeah.
Yes,
that's right.
And plus, the skull will get thick, and there'll be long-term consequences.
Yeah.
Question for me. There are some patients that, when shunted, the proximal catheter sits in a cistern rather than the ventricles.
And works fine.
It works fine, yes. But in the long term, those are some of the patients that are the most shunt dependent as they get older. Why?
Because that's the same thing. It probably is that the initial cause of their hydrocephalus is venous hypertension.
Yes.
And so that the cortical subarachnoid space participates in it. And so your shunt in the cistern was probably a great thing to start with.
But in the long term, these are these kids, when they become adults, when they have a shunt malfunction, they're the ones that deteriorate the fastest.
And with ventricles getting bigger?
No. Not necessarily.
No. So it's the cortical subarachnoid space that's the problem. And so you have to do something. Whatever you do, that's the old, another. I'm so controversy about so many things, but I often will put a catheter in the cisterna magna to balance the pressure between the ventricle and the cortical subarachnoid space. But you have to, in those patients, you need to access the cortical subarachnoid space.
Thank you. Any other questions? Well, that was a great discussion.
And a good time.
Thank you.
Thank you, Hal. That was very good. I liked it.
Yeah, I did too.